So I'm consultant anesthetist working from Ashraya Hospital. So title of my study is a study to assess the effect of pre-treatment with ROCURONIUM bromide in reduction of etomidate induced myoclonus during anesthesia induction. So induction agents are the drugs that when given intravenously in an appropriate dose cause rapid loss of consciousness. Etomidate is an intravenous anesthetic, a carboxylated imidazole derivative widely used for induction and maintenance of anesthesia. It is characterized by stability, minimal respiratory depression, and cerebroprotective effects. The effect of increased coronary perfusion along with the negligent sympathetic response make it an ideal induction agent of choice in all ischemic heart disease patients. However, since it is associated with some disturbing side effects such as pain on injection, post-operative nausea, vomiting, adrenal suppression, and superficial thrombophlebitis and myoclonus. The mechanism of etomidate-induced myoclonus appears to be disinhibition of subcortical structures that are normally suppresses extrapyramidal motor activity. There are few studies which have evaluated the effects of rocuronium on myoclonus after etomidate injection. Aims and objectives of my study are to investigate the effect of pre-treatment with priming dose of rocuronium on the incidence and severity of myoclonus during anesthesia induction with etomidate. So these are my inclusion and exclusion criteria. So coming to the methodology, so thorough pre-anesthetic assessment was the patients the day before surgery, and all specific investigations were sent before, and patients were evaluated for any systemic diseases, and basic investigations like hemoglobin, total blood count, and differential count with ECG, chest X-ray were done. The procedure of general anesthesia and study was explained to the patients, and after obtaining informed written consent, patients were randomized into two groups from the numbers generated from the www.random.org website, and they were assigned to one of the two groups, that is group S, saline group, and group R, which is rocuronium group, each including 40 patients. And intraoperatively, like monitors were attached, which included standard monitoring, and all patients were pre-oxygenated with 100% oxygen for 3 minutes and pre-medicated with standard institutional protocol. Group R patient received 0.06 mg per kg of rocuronium bromide diluted to 5 ml IV over 30 seconds, and group S patient 5 ml of normal saline over 30 seconds. And after oxygen supplementation through mask was given during this period, after 3 minutes of the study drug injection, etomidate 0.3 mg per kg was administered over 30 seconds. Immediately pain on injection and myoclonic evaluation was done. After 2 minutes of etomidate induction, injection fentanyl 2 microgram per kg and midazolam 0.05 mg per kg was administered, and tracheal intubation facilitated with injection rocuronium 0.1 mg per kg, and anesthesia is maintained as per institutional protocol. These are the parameters measured during the intraoperative period. And pain on evaluation and myoclonus evaluation and time to extubation, and from the time to extubation, that is counted from the stoppage of inhalational agent to the extubation of trachea, and recovery profile of the drug were evaluated accordingly. And in the immediate post-operative period, heart rate, SpO2, SPP, DBP, and mean arterial pressure, respiratory rate, nausea, vomit was monitored for every half an hour for the period of 2 hours. And appropriate statistical analysis was done. And age, coming to the results, age, weight, height, and BMI were comparable between the two groups. And coming to the incidences of myoclonus, in rocuronium group, 40% of the patient had myoclonus, and in saline group, 75% had myoclonus. And there was a significant difference in myoclonus incidence between the two groups, and the odds ratio being 4.5. So that is, which indicates the incidence of myoclonus was 4 times more in the rocuronium group compared to the saline group. Coming to the grading of myoclonus, in rocuronium group, 60% had grade 0, 12.5% had grade 1, 22.5% had grade 2, and 5% had grade 3 myoclonus. In saline group, 25% had grade 0, 10% had grade 1, 35% had grade 2, 30% grade 3. And there was significant difference in the myoclonus grading between the two groups. For grade 1 myoclonus, odds ratio was 1.92. For grade 2 myoclonus, odds ratio was 3.7. And grade 3 myoclonus, odds ratio was 14.4. Heart rate, systolic blood pressure, diastolic blood pressure, and mean arterial pressure were there were no much statistically significant difference between the two groups, except for few intervals of time. Coming to the discussion, going as per the review of literature, there was a study conducted by Salman and a group to compare the efficacy of pre-treatment with dexmedetomidine 0.5 microgram per kg over 60 seconds and midazolam 0.25 mg per kg on etomidate induced myoclonus. It was observed that both agents did not cause severe myoclonus, and there was no statistical difference in the mild and moderate myoclonus between the two groups. And timing with ROCURONIUM could effectively suppress etomidate-induced myoclonus. By using low-dose ROCURONIUM as pre-medication, etomidate as a valuable drug could be properly used in induction of anesthesia without myoclonus as a prominent adverse effect. Coming to the conclusion, pre-treatment with a priming dose, that is 0.06 mg per kg of ROCURONIUM bromide, modifies the induction of anesthesia with etomidate by reducing the incidence of myoclonic movements and preserves the advantage of etomidate, that is cardiovascular stability, minimal respiratory depression, cerebroprotective effects. These are my references, and thank you.
Thank you very much, ma'am, for your presentation.
Thank you, sir.
Do we have any question for this presentation? Thank you, ma'am. We don't have a question for you.
Thank you.
Thank you for participation.
Thank you, sir.